So my objectives will be to discuss mitral valve disease patients who benefit from transcatheter interventions, and also to identify emerging transcatheter mitral valve therapies that are under investigation, and then also recognize some important factors that help us determine whether patients are candidates for transcatheter mitral valve replacement therapies. I'd just like to briefly go over the fundamental differences between primary and secondary mitral regurgitation. This is important for us when we're selecting patients for potential transcatheter interventions. Primary mitral regurgitation refers to abnormalities of the mitral leaflets, and this can include prolapse or flail leaflets, also includes other etiologies including endocarditis. And you can see in this picture the patient has a flail anterior leaflet here. On the right-hand side depicts secondary mitral regurgitation, and this is typically referred to as a disease of the ventricle, and that's because the ventricle enlargement serves to tether the leaflets to some degree and varying degrees, and that reduces the amount of leaflet coaptation. Now, part of functional or secondary mitral regurgitation also includes annular enlargement as well. And there's recently been a third group of patients called atrial functional MR, which have been classified as having a normal ventricular ejection fraction, but severe atrial enlargement, which pulls apart the leaflets and reduces the coaptation. So these are very different mechanisms of mitral regurgitation, and we treat them differently. So our current approach to considering patients for interventional therapies includes the classification, primary or secondary mitral regurgitation, and then also what is the patient's risk for conventional surgery. For primary mitral regurgitation, our gold standard treatment is a good surgical repair, and that produces the best long-term results. So that's our first option for those patients. But if they're high risk for surgery, then we would consider them for edge-to-edge repair or an investigational therapy, which includes transcatheter mitral valve replacement technologies. For secondary mitral regurgitation patients, it's very different. We do consider them for surgery, but oftentimes they're not low risk, and many of these patients are higher risk, and we're leaning more on our transcatheter therapies, which includes edge-to-edge repair or transcatheter replacement. Now, just briefly about edge-to-edge repair. Many of you are familiar with this, and this has been clinically approved now for many years for primary MR, but the COAPT trial led to the approval of this for secondary MR more recently in the last couple of years. And the COAPT trial was published in 2018, and this randomized patients who had heart failure due to secondary MR to either guideline-directed medical therapy or guideline-directed medical therapy plus edge-to-edge repair with MitraClip. And the results were pretty dramatic in terms of the reduction in hospitalization for heart failure, which you see here, and then all-cause mortality as well was less at 2 years in the patients who underwent edge-to-edge repair. So very positive result that led to the approval of MitraClip for these patients. But an important caveat is that the type of patient and the factors are very important, because there was a negative trial in this population which was published around the same time, the MITRA-FR trial of about half as many patients, and they examined 1-year outcomes, and this actually had a neutral outcome, and there was no benefit of edge-to-edge repair in this trial. And some of the hypotheses for why that is include that the mitral regurgitation was less severe in patients in the MITRA-FR trial, with the EROA being 0.3 instead of 0.4, which was in the COAPT trial. And then also there was more ventricular enlargement in the MITRA-FR trial relative to the COAPT trial. But one of the most important things is that guideline-directed medical therapy was more rigorously confirmed in the COAPT trial. And this was really an important part of being enrolled in the COAPT trial, being evaluated by a heart failure specialist and confirming that their meds were optimized. So those are some of the reasons why it was explained that the results were different in these trials. So when we're selecting patients for edge-to-edge repair, we go based on the COAPT trial, and that includes confirming optimal medical therapy and also considering cardiac resynchronization therapy in patients who may be candidates. In patients who have primary mitral regurgitation, there's a lot of different therapies for us to consider. We mentioned MitraClip. There's also the Pascal device, which is an edge-to-edge repair device similar to MitraClip, but with some subtle differences, including the material and the controls and also the size of the device. And this has just completed the enrollment in the pivotal trial, which was the CLASP 2D trial, which is a trial comparing the Pascal to MitraClip. So the results of this are eagerly anticipated. For transcatheter mitral valve replacement, there are several ongoing trials, including the SUMMIT trial of the Tendyne device, which is a transapical tether-based replacement device, the ENCIRCLE trial, which is of the SAPIEN M3 valve, which starts with a dock that encircles the mitral apparatus via transeptal approach, and then a balloon expandable valve is inserted inside of it. We'll go through that a little bit next. And then also the Apollo trial, which is a pivotal trial of the Intrepid valve, which is a self-expanding transeptal device as well. We are also actively enrolling in the Mitral 2 trial, which is looking at the balloon expandable SAPIEN 3 valve in patients who have severe mitral annular calcification. And these patients are traditionally very high risk for surgery. And we'll talk a little bit more about that later on in the talk. Additionally, there are important chordal repair options that are being investigated. The Harpoon is a transapical chordal repair device that's currently being studied and enrolling patients actively. There are also transeptal chordal repair devices that are in varying phases of investigation right now too, so that's an area of active study. This is an algorithm, and I've adapted this from my colleague, Dr. Myra Guerrero. And this is looking at patients with secondary mitral regurgitation, and this is our approach to treating these patients. Now, of course, we always confirm that they're on guideline-directed medical therapy, and that includes a heart failure specialist evaluation. Then we look at the LV ejection fraction and end-systolic dimension. Typically, patients with an LV end-systolic dimension of less than 70 and EF of greater than 20% are the ones who were enrolled in the COAPT trial, and those are patients who may benefit from edge-to-edge repair. Then we look at their anatomy and whether it is favorable or not. That includes looking at the leaflet length, the gaps, and also the degree of baseline stenosis in the mitral valve area. Lots of different anatomic features are looked at. And if they do have favorable anatomy, we can either proceed with MitraClip or we could consider randomized trials. We have the Class 2F trial comparing Pascal to MitraClip, and also the SUMMIT trial comparing Tendyne to MitraClip. If the anatomy is not favorable for edge-to-edge repair, there are non-randomized arms of several trials, including SUMMIT, Apollo, and the ENCIRCLE trials for transcatheter replacement, and this requires a cardiac CT be performed. In patients who fall outside of the COAPT trial inclusion criteria, these are patients who are really outside the realm of evidence, and so these are patients that may be candidates for other options. Of course, we should evaluate them for transplant candidacy and LVAD candidacy, and if they're not candidates, then there's a group of patients that are currently underserved, and more therapies are needed for them. This is an example of a SAPIEN M3 device that we performed, and you can see the transeptal delivery system here in this RAO view, and here we have the coil dock that's been encircled around the mitral apparatus, and this is followed by implantation of a modified SAPIEN 3 valve, which has a skirt along its entire length. So very similar to how we do our transeptal valve and valves, which we've been doing for many years, once you've placed the dock. So the most challenging aspect of this is positioning the dock. and these patients are carefully selected based on their pre-procedural CT and echo imaging. The first-in-human SAPIEN M3 experience was favorable, with 9 out of 10 procedures being successful, and this was published in 2019, with 0% 30-day mortality and a short length of stay, and the majority of patients had grade 1 or less residual, grade 2 or less residual mitral regurgitation. But paravalvular leak is an area that continually needs improvement in this device, and it's being studied in the ENCIRCLE trial. There have been some updates to the device that have occurred since that time as well. So more data is eagerly anticipated on the SAPIEN M3 valve. The Intrepid transseptal device is also another device that is being studied in a ongoing pivotal trial, and this was the data from the early feasibility study that was just recently published. 14 patients, 14 out of 15 underwent successful implantation, with 1 patient having conversion to open surgery. You can see high success rate, less residual MR with this device. 100% of patients had none or trace residual MR at 30 days. And significant improvements in the NYHA functional class, and 0% 30-day mortality, stroke, reintervention, or new pacemaker implant. Now, importantly, there was significant access site bleeding and ASD closure rates in this early experience. I think another important point of all the TMVR trials is that the screen failure rate has been quite high. In many cases, it's up to 2/3 of patients who are not candidates due to various anatomic reasons, and that includes the annulus being too large, the ventricle being too small, or a risk of severe LV outflow tract obstruction. Those are currently some of the biggest challenges and hurdles that have to be overcome. Probably our biggest experience with transcatheter mitral valve replacement comes from patients who have severe mitral annular calcification. And these are patients who are inherently high risk for surgery because of that severe mitral annular calcification and all the comorbidities that come with it. Some of these patients have had prior radiation, such as this patient, 67-year-old woman with dyspnea and previous Hodgkin's disease treated with mediastinal radiation. Other comorbidities as well, chronic kidney disease, history of DVT and PE, and she developed radiation-induced valve disease and had a prior aortic valve replacement. Given her high-risk status, she was evaluated for enrollment in the mitral trial. So her mean mitral gradient was 11, and her valve area was 1.3, consistent with severe MS. And you can see the TEE color Doppler images here. You can see the restricted leaflet motion, and you can appreciate the severe annular calcification. And there's also concomitant mitral regurgitation noted. A gated cardiac CT is one of the most important tests that we do for these patients to see if they're candidates. In the diastolic phase, we measure the mitral annular area, which you can see being measured here. This is the posterior bar of MAC, and then there's some scattered anterior annular calcification as well. And then up here is part of the aortic prosthesis. And the annular area was 650 square millimeters, so this would be in the range that we can treat with a 29 millimeter SAPIEN 3 valve. We also look at the intercommissural distance, and the larger this is, the higher the risk of paravalvular leak, particularly at the areas of the trigones. This is just another view of it, showing that the aortic prosthesis would provide some anterior anchoring as well. So these images are important for us to ensure that there's enough circumferential calcification to anchor a balloon expandable valve. Since the balloon expandable valve is not dedicated and it's not designed for this purpose, we really need to ensure that there's enough calcium present. We then also look at additional imaging to look at the size of the left ventricular outflow tract to determine what the risk is of LV outflow tract obstruction, since the anterior leaflet is displaced into the outflow tract by the transcatheter valve. In this case, you can see with a virtual valve overlaid on the mitral position that there really is not much room in the LV outflow tract, and the frame to septum distance is very low. And you can also appreciate there's basal hypertrophy, really concentric hypertrophy, but it's very pronounced in the basal anterior septum. And here is looking at the LV outflow tract area on short axis here. And at baseline, it's 351. But when you project the 29 millimeter SAPIEN valve, then the outflow tract area is very small at 139 square millimeters. So this is below the threshold that we would be comfortable with. And we have previous studies from the early experience that a neo-LVOT area of less than 190 would confer a high risk of LV outflow tract obstruction. So in these situations, we consider alcohol septal ablation, and this is off-label use of alcohol septal ablation and still in the investigational phase because there are patients that don't have LV outflow tract obstruction, but instead we're using the ablation as a way to reduce the LVOT obstruction risk and enlarge the outflow tract. So in this case, we identified an appropriate septal perforator, and this was engaged through traditional alcohol septal ablation techniques. The more proximal branch was cannulated, and ablation was performed with 1 cc of dehydrated alcohol. We used simultaneous transthoracic echo, as you see up here on the top left image, to confirm the appropriate region of the septum is opacified with the contrast. And once we have confirmed the ablation, we then bring the patient back 4 to 6 weeks later for follow-up CT imaging. In this case, it was done only 3 weeks after, which is something we've learned that we can even see the changes that early, as early as 3 weeks. And in this case, you can see that the basal anterior septum is now different. It's become effaced, and we have a much wider space in the LV outflow tract. And whereas before there was only 1 millimeter, now you have 6 millimeters here on the long axis. And when we look more detailed at the 3D, with the 3D modeling, and we measure the neo-LV outflow tract area, it is now much larger, and we now have a much lower risk of obstruction. So we did proceed with this patient in performing our transseptal balloon expandable SAPIEN 3 valve. You can see our safari wire in the ventricle here and the balloon expandable valve being expanded. And the patient ended up having a good result, and there was mild residual paravalvular leak and a mean mitral gradient of 5 millimeters of mercury at follow-up. And the patient had significant improvement in her quality of life following the procedure. This is just another example of a patient we treated many years ago who had radiation heart disease and severe MAC. You can see the 3D mitral view here, a very restricted valve and a gradient quite high at 16 millimeters of mercury. And after the balloon expandable valve was placed, the gradient lowered to 4 millimeters of mercury. And this patient has been doing well for many years since that time. The first prospective study led by Dr. Guerrero, which we were a big part of at Mayo Clinic, completed enrollment, and the 1-year results were published last year. This was the mitral trial, and the transseptal valve and MAC 30-day mortality was 6.7%, with a 1-year mortality that was significantly lower, more in the 70 to 80% range, 1-year mortality, which mostly reflects the comorbidities of the population. But these results were much better than previous registry studies of this therapy as it is evolving. You can see that the majority of patients had improvement in NYHA class both at 30 days and 1 year, and this was there was improvement both for the transatrial deployment of the valve and the transseptal, which was the majority of patients. And also 6-minute walk and quality of life by the Kansas City Cardiomyopathy Questionnaire were also improved in both arms of this study at 30 days and 1 year. The Mitral 2 trial of more updated techniques with improvements in pre-procedural planning and also additional techniques is currently enrolling. This is just one of the publications that our group, along with the Henry Ford group, published looking at pre-procedural alcohol septal ablation, the initial experience of it, and the effectiveness of it. And we have since performed many more of these. This is just another example of a patient before ablation and after, and you can see the changes in the septum that occur with ablation to enlarge the LVOT and prevent this potentially fatal complication of transcatheter replacement. We've just recently looked at the safety and outcomes of septal ablation prior to TMVR, and we found that in general, the patients undergoing TMVR had less septal hypertrophy than traditional HCM patients, and accordingly received a lower volume of alcohol compared to HCM patients. Despite that, they did have a higher risk of complete heart block requiring permanent pacemaker at about 30 to 35% in the patients who were undergoing evaluation for TMVR, compared to 20% in the HCM population. But 30-day mortality was 0%, and so this is the first study to look at the safety and short-term outcomes compared to HCM, looking at septal ablation prior to TMVR, and this is currently under review. Another procedure that we've been doing is the laceration of the anterior mitral leaflet through transcatheter techniques to facilitate TMVR, and this is called the lampoon technique, and this was initially developed at the NIH by Dr. Khan and colleagues, and this is just an example of a case that we did, and we typically use this in cases where alcohol ablation has not enlarged the LVOT enough, or if patients have other anatomy that makes this more favorable, we would proceed with the lampoon, and if this effectively splays the anterior leaflet so that when the transcatheter valve is implanted, the anterior leaflet is divided and there's more space in the LV outflow tract for blood to go through the open cells of the SAPIEN stent frame. So and this includes having two transeptal catheters and perforating the anterior leaflet with a wire, snaring that wire, and then using cautery to lacerate that leaflet, and also using a balloon pump. And then this is followed by, on the right, implanting the transeptal SAPIEN 3 valve right away. So this is done after a lot of careful pre-procedural planning using all the imaging that I've shown you already. So that's just a highlight of some of the transcatheter mitral therapies that we have available in 2022. We discussed that transcatheter edge-to-edge repair with MitraClip is approved for high-risk primary MR patients with suitable anatomy, but also secondary MR patients who are optimized on guideline-directed medical therapy. And then several TMVR therapies are in the pivotal trial phase to determine their future role in high-risk patients with mitral valve disease. And we also discussed strategies to enlarge the LV outflow tract or reduce the risk of obstruction, and that includes septal ablation and also anterior mitral leaflet laceration. And then there's also a lot of interest in transcatheter chordal repair devices, and these are currently in the early phases of investigation.